So moving on to gaps specifically impacting the heart and lung programs. First, we have, all right, button's not working, hemodynamics. So for this item, what CIHI is asking for is for, at the time of listing, systolic and diastolic pulmonary artery pressure, pulmonary capillary wedge pressure, and cardiac output. And at the time of transplant, systolic, diastolic, and mean pulmonary artery pressure, pulmonary capillary wedge pressure, pulmonary vascular resistance measured in Wood units, pulmonary vascular resistance reactivity, and cardiac index plus cardiac output in liters per minute per meter squared. And this would be applicable for lungs only. So in its current state, some of these measurements are captured in the CPX/RHC complete section in the pre-transplant heart clinic power form at the time of listing. In part 1 of our analysis, we found that the aforementioned section would be available to heart patients, but not lung and pediatrics at the time of listing. We do have confirmation that this is not relevant for the pediatric MOT program, so what we propose for the options here will be specific to adult, heart, and lung. So here we think it would be valuable to add the CPX/RHC complete section to the new pre-transplant power form like we've discussed before. This would ensure fields are available for documentation with CIHI's requirements, but there would be potential changes to documentation for heart and lung pre-transplant nurses. This would also be a new ask for the EDD itself. In the next couple of slides, I'll also go over variations for how this could be implemented to meet all of CIHI's requirements. So part 2 of our analysis shows what is currently not captured in this section, which is cardiac output and pulmonary vascular resistance. What is currently available for capture is also in the form of free text. So here we recommend that in addition to adding the missing cardiac output and pulmonary vascular resistance reactivity columns, the pulmonary arterial pressure section should also be modified to have systolic, diastolic, and mean readings in separate columns. What is currently a combined field for thick and thermodilution cardiac index should also be separated into their respective columns. The free text field should be changed to numerical fields and alpha responses as pointed out on the slide. And this would help meet CIHI's requirements and produce better quality data, but it's going to come at the cost of new build for ambulatory impact to the pre-transplant nurses transcribing this information currently. And it would also require slight alteration to the way things are entered. One thing to note is that it seems like pulmonary arterial pressure has historically been entered as systolic/diastolic/mean in its current form. This will be addressed in the next slide. So option 2 is essentially the same as option 1, but with the added column next to the comments to reflect historical entries for pulmonary arterial pressure. This would make it easier for us to separate what's been entered before and what has been entered since the new requirements. Option 3 presents a more simplified approach to only technically add to the section for what is really missing. So here our recommendation is to add cardiac output and pulmonary vascular resistance, with the former only taking numerical response and the latter having a set of alpha responses as shown before. The advantage would still be having fields to fulfill CIHI's requirements, but this would still need new ambulatory design resources and would still impact how cardio output is transcribed. There would also be the additional limitation for relying on the end user to document this information consistently, because any variation could cause issues with extracting the data. So like we mentioned for how data is historically and currently entered, missing a slash in between measurements or having an added space somewhere, these could all affect the outcome. We also have a clinical question for the clinicians here. We're hoping you can help us clarify whether the Fick or thermal dilution value is transcribed for cardio output.
It depends. I think most of the time the thick is done, but it's
Okay,
not always guaranteed that a thermal dilution is done.
I see.
The other issue with this is, if I understand correct, this is the post-transplant or intra-op pressures that it's asking for, right?
Give me 1 second here just to confirm. This is for at the time of listing. So we're asking what we're hoping to capture is prior to the transplant happening.
Then I do think we have that. We currently do enter that. Josie, am I correct? Minus these additional fields.
Right.
Correct.
Okay.
Yeah.
I appreciate that. And currently, with the field for Fick and thermal dilution cardiac, sorry, I guess this would also be a good time to ask about the Fick and thermal dilution cardiac indexes. For those readings, is one over the other consistently entered, or is it entered in more interchangeably?
I would say for us, we do it thick always, and then yes, every once in a while thermal dilution when it's done.
I see. But if thermal dilution would have to be filled in, it would be in the same field, correct?
Correct, with the slash mark. We do indicate F for thick
Okay.
with the number, and then slash, and then we do TD for the thermal dilution with the number.
Gotcha. Okay, thank you. That's really helpful. So, between three options that we're offering, is there one that you all would prefer over the other in terms of capturing what we need based on CIHI's requirement?
Just to add in from the lung program, because we currently input none of this data into any power plan or anything. So this would be a totally new addition to our workload and our workflow for activations or for listing. Because we historically, at some point during the workup, usually within 1 to 2 years of somebody getting listed, do a heart catheterization. So that's where that data would, so we technically have it, but it would be a completely different workflow because we're currently not documenting this anywhere.
I see.
It's just in the cardiac cath report.
Okay, no, thank you for pointing that out. But what we're hoping to understand, I guess, here is that because right now, I guess the preferred source for getting this information would be from Cerner. If we were to ask for a new way of entering or transcribing this information from the cath report, which of the three options would you say is more preferable over the others?
Preference-wise, I don't think it makes I don't see a huge amount of difference from us because we wouldn't be pivoting from something we're currently doing to something we would change into doing. It would just be a completely new thing for us either way. So this we would be transcribing it however you guys create the form.
Okay, that's okay. So we can defer to I guess we can defer more to the heart program for this. Folks from the heart program, I would believe option 2 is the more comprehensive of the bunch, but would like to hear your thoughts on whether this is something we should really consider for moving forward, or if you have any difference in thoughts.
But just to clarify, I guess the column on the very, very right, the pulmonary arterial, it says historical, so that would pull over from the previous one?
Correct, yes.
Okay. But if we have them all dated correctly, I guess we wouldn't need that, right? Because we would be able to look over at the previous
I'm sorry,
numbers.
I'm not quite understanding the last part of your question.
So I guess that last column is historical PA pressures. Is that historical from the previous ad hoc before these changes would happen, or is it just pulling over from what we entered in before? That makes sense.
Kaylee, would you be able to clarify that?
Yeah, so we put this option in there because we noticed that this form currently pulls forward your previous documentation. And so we weren't sure how that information is used currently. But if you do need that information still available to you, then we could add this column on the right-hand side so that you can still see that historical information. But if you don't really use that or need that historical information, it would be available in results review. We wouldn't have to add that extra column there. But it's just because we'd be removing that column to put in the separate measurements there, that wouldn't pull forward anymore.
Okay. And then option 1, can we just look at that? Oh, so we can still put in comments regardless, like ad hoc comments if we wanted to. Because I think from us, I don't think it's necessary to have that extra historical column, because when we are looking at numbers for our patients, we do look back, but I don't know, Wynn, what do you think? I don't think we need the historical part.
These are smart templates, right? I'm sorry, I don't know if I'm using the correct Cerner terms anymore, but whatever we enter in, it drops down to a log format of it. Does it not, Josie?
This particular one doesn't actually. There are smart templates within that form, but this one has the pull forward function instead of an actual smart template below.
Then could it be changed to a smart template with these added fields?
I'll defer to James on that one, and whether or not you could still pull that in for that historical information in at this point, or if it'd only be going forward.
Theoretically, we could, if we were to change this and use a smart template.
But another thing is, these are all transcribed information. So the CATH report, I think it's a MacLab/CBI source data entry now. I don't know if that's actually a better place where you want to pull the information. But just knowing that if you pull it from here, these are all transcribed information that could be full of errors.
Thank you, everyone, for getting your thoughts on this. So if I'm understanding correctly, there's more work that needs to be done looking into what was said just now. But if we were to move forward with the options that are proposed, we'd be going with option 2, right?
It sounded like option 2, but changing it instead of having a pull forward function, changing it to a smart template.
Okay. Definitely something we can look forward into, but good to know that option 2 can be agreed upon.
And just out of interest, what is the barrier to just pulling the data directly from CATH reports? Like when data collection is happening, like is it just a time consuming process that we're trying to smooth out by creating these power forms? Because just like Wynn said, so they're transcribed data that we're transcribing in different places that already exists somewhere. What's the barrier to just pulling that information straight from the report itself?
Yeah, Kaylee.
I think we need to probably take away the MacLab and CVI source to see if that is something we could get information from, if it is being entered discreetly there. I don't know enough about the changes that have been made with those updates recently.
Good. Alrighty, so we'll take this information back and do some more investigations. Okay. So after hemodynamics, we move on to what will only impact the heart program. And for starters, we'll have the CAV screening date. So what CIHI is looking for is the date that the recipient was screened for CAV, and this most likely will have a workflow impact for the post-transplant nurses on the data following up. We found that this information can be transcribed by the nurses from the cath lab reports into post-transplant power form through the CAV surveillance section. And we also found that CAV was excluded from the pediatrics transplant power form because these results are not currently being transcribed, and is instead trended using the cath lab reports. So with this appearing to be a gap for pediatrics heart and CAV info currently not able to be entered into discrete fields onto the pediatric transplant form. We propose to add the CAV surveillance section mentioned before to the pediatrics transplant power form. And since this recommendation concerns the heart program at BC Children, and unfortunately we do not have the program's representation for today's session, I will touch base with the appropriate subject matter expert offline to get a confirmation on this. Before moving on, are there any concerns from BCCH site informatics? If not, then we will move on to the next issue. So up next would be the CAV grade, and what CIHI wants is a grade definition from a grade classification from 0 to 3 and unknown. And here we have a visual on what the classification entails. Okay. And with regards to workflow, this has the potential to also impact the transplant, post-transplant nurses on the day of follow-up. So with the CAV grade, the current state that we found is that CAV surveillance can also be found under the post-transplant power form, but CAV grade is not currently part of that table. So then our analysis would be, our analysis at this time is that CAV grade is not currently captured in the CAV table, and therefore we propose the option for adding a column for CAV grade next to date with grade 0, 1, 2, 3, and unknown as alpha responses. This would allow us to fulfill the CIHI requirements, but again, this may have impacts to the post-transplant nurses who must transcribe this information from the cath lab reports, and also there needs to be ambulatory build resources required. Any feedback and comments or concerns for this recommendation?
So this would yeah, go ahead, Wynn. Sorry.
Yeah, like we don't currently use these classification. We do categorize how severe it is, but not under these definitions. But I suppose it's not that much of an ask, right, Josie, to just click an extra click when you guys enter the info anyways.
Yeah, I don't think it would be that much of an ask like you mentioned. And we would confirm it with our physicians at the time that we would be reviewing. So
okay,
I don't see it being a problem.
Thanks very much. So then I'll take it as we can move forward with this option then. Great, thank you. So moving on, we have for CAV, it's mTOR prescribed. And what CIHI is looking for here is indication of whether the recipient was prescribed mammalian target of rapamycin inhibitors when they were diagnosed with CAV. CIHI here is just requiring a yes, no, and unknown. This, aside from impact to pharmacy, it could potentially impact post-transplant nurses as well based on the recommendations that we'll be making. I'll make sure to show that later on. So for the current state, we recognize that it's documented under medications, so BPMH. And what we found is there's no discrete field for capturing the information of mTOR prescribed upon recording CAV on file. Documentation is being done in BPMH, so therefore the first option that we propose is to use a logic-based approach to compare the status of mTOR on file and the date of CAV entries to fulfill the identification of yes, no, and unknown, if that's feasible. Our mapping would just be straightforward as a yes for when the choices of taking as prescribed or taking not as prescribed and on hold are filled out. For unknown, it would be unable to obtain information, investigating compliance, and for no, it'll be mapped to no longer taking, or if nothing is found on BPMH. Obvious advantage to this is no documentation, but this would require reporting team to build, and there would also be effort required to maintain the list of medications if new mTOR medication enters the market. So we have a backup option, option 2, and that is to add mTOR prescribed DTA to the CAV table that we previously discussed with alpha responses for yes, no, and unknown. This would mean no reporting team build or maintenance effort that's needed if new medication were to enter the market. However, this would require a new ambulatory build, and this would put more strain on the nurses' workflow as they would be required to transcribe this information from chart. So with option 1 and 2 outlined, can we get your thoughts on which one we should proceed with?
I feel like this is not as straightforward because sometimes, depending on how many years out the patient is post-transplant, we like it might take, there might be a lag in time between deciding whether we put them on it to the time when the cath report was done. So the nurses will be transcribing the cath report at the time the procedure is completed or shortly after, but the discussion as to whether they'd be put on something could be months after that.
I see.
So, and I don't know if and Josie, yeah, I'll let you take over because like that would mean the nurse having to remember, go back in and click that mTOR, yes, no.
Yeah, no, agreed. I don't, yeah, it would just be an added thing for us to have to look back on. And to be honest, workflow, like sometimes we wouldn't even have that time to go back and look back at the history.
Understood. Am I understanding this correctly? Then perhaps there's something still missing from CIHI's definition too, because there's not always a direct linkage between when the patient gets diagnosed with CAV and gets put on. So when a patient gets diagnosed with CAV, it may not be immediate for them to be put on the mTOR medication, correct?
Correct.
Yes.
Yeah.
Because we have program decisions as to whether we put them on it or not, but we tailor it to the patient's clinical status and stability.
Okay. So in this case, I believe from what I gather, and please correct me if I'm wrong, I believe what is mentioned is option 1 would be more preferable from a workflow perspective, but at the same time, we may need more clarification from CIHI for what is the gap that they would be accepting between when a patient gets identified with CAV and when they get put on the medication.
Yes, I think that would be helpful.
Sounds good, definitely. And if BCT, who is present, can also kindly make sure to note this just in case something gets missed. Please and thanks. Okay, so I guess now we can move on to the next piece, which is CAV screening methodology. What CIHI is looking for here is the method used to screen and diagnose for CAV. So the choices that they're giving us is angiography, stress, echocardiography using dobutamine, and intravascular ultrasonography of blood vessels. This again could impact the post-transplant nurses. So current state of this is that the method used for screening and diagnosis of CAV is documented as free text in the CAV surveillance table. Our analysis shows that there could be risk of data entry errors and data quality issues in free text, so we're recommending for this to be changed to alpha responses corresponding to what CIHI is asking for. And that is also what we're presenting in our options. Advantage here being meeting CIHI's requests and getting better data quality. But of course, this could result in a minor change in workflow, and you may need to utilize the comments for any variations to the procedures. We also have a question for the clinicians present, and that's, are there any other fields that may need to be added as the alpha responses in order to properly support clinical needs? Just in case CIHI missed something.
Josie, do we still do IVUS?
So yes, we do IVUS, so for our older patients, but the ones that have been transplanted in the last couple of years actually use OCT angiography. Yeah, so that's missing from there.
Okay.
But
so
it's
that's
so you'll need angio plus IVUS or angio plus OCT.
okay.
Yes,
right?
But then there's also angio for patients who are more than 5 years out who no longer have IVUS or OCT. So it should be angiography, the stress echo, angiography with IVUS, and angiography with OCT, to be specific.
All right, we can definitely note this down and make sure that gets added here. But as for the proposed option itself, no issue with that, right? Sounds great. Thank you. So then we'll move on to the next piece, which is for CAV diagnosis. And what is being looked for here is result of CAV screening to indicate whether the recipient was diagnosed with it. What CIHI is looking for is a response for positive, negative, or undetermined.
How's that different than using the grade that was proposed earlier?
I believe the grade indicates severity, but what CIHI is looking for here is whether the patient has a diagnosis of CAV listed.
I feel like it's asking the same question a different way. Because if we put in the grade, then it's positive, like they have it.
I see your point. Yes. No. As I'm thinking about this, yeah, that this may be something that we may need a little clarification from CIHI. Kaylee, do you happen to have any more thoughts on this?
No, I agree with that. It could also be something that if that is the case, then we could use some logic to say, you know, if any of these were graded, then that means positive. If they weren't graded, they were negative. And if it wasn't filled out, undetermined.
Yes, I think that will be, yeah, take some extra clicks away.
Definitely.
Great. That's fine.
Appreciate you pointing that out. So I think what we have next would still be a little relevant, but based on what was just pointed out now, that's something we can add to consideration when we're implementing the solution. So right now, as we've discussed, it seems like this can be indicated if a grade were entered, but also I believe this is also entered under diagnosis and problems or in clinic notes. So then our analysis for this piece would be that it's possibly not always documented discretely in where we want, which is diagnosis of problems. So then option 1 for us is to perhaps build a logic-based approach to map CAV screening date from the CAV table to a relevant ICD-10 diagnosis for cardiac allograft vasculopathy. Vasculopathy of cardioallograft or normal coronary angiogram. So the mapping is as shown below. So positive would be a patient that has relevant diagnosis within 30 days of screening, negative for normal coronaries within 30 days of screening, and undetermined being neither or normal coronary angiogram, cardiac allograft vasculopathy, or vasculopathy of cardiac allograft diagnosis found greater than 30 days. We do have a question for the clinicians present again, though. So knowing a little bit more about where CAV is documented now, we do still have the remaining question of what is the typical length between diagnosis of CAV to documentation?
Want me to answer that, Josie? Okay.
Yeah. I guess I can answer it. It's usually less than 30 days. Typically what happens is when they come in for their angiogram, the cath lab does hand us the cath lab report, and we do enter it in as soon as we can. But sometimes patients don't have an appointment for another week or two, and then that's when we review it with the doctor. Unless, of course, there's CAV that's so severe, we do review it right away with our clinicians. So 30 days, I think, is quite a long lag time between. We do it quite quickly.
I also think you guys can build the logic kind of like the previous slide. If we select moderate to severe, whatever the equivalent grade is,
Oh, okay.
then that will be their diagnosis.
Yep. That's definitely something we're that's definitely something we're noting down to think of adding as a part of the solution. But I guess here would also be a good time to clarify. Would CAV typically get entered under diagnosis and problems at all?
No, and this is, I think, a bigger problem beyond this particular disease process, I suppose, because not all the codes are the same. So I'm not describing this correctly. Like I know there was a lot of work done, like when you put in CAV, there could be more than one selection. When you put in ischemic cardiomyopathy, there's more than one selection. So first of all, no, our physicians are not routinely putting in the diagnosis. And second of all, even if they were doing it, it's not consistently, not everyone's selecting the same one. So if you're going back to Cerner to pull diagnosis of who had CAV, you'll need to know all the selections that are there and all the possible ones that the physician would have selected.
I see. Okay. In this case, Kaylee, correct me if my understanding is incorrect, but would this be something that we'll have to look further into offline then?
Yeah, I think that we would consider all possible ICD-10 diagnosis to account for that variation in what providers do choose. I think, though, using the logic based on the grading, we would have to take that back to CIHI to see if they'd be okay with that type of logic or if they would be looking for this diagnosis.
Thank you for clarifying. So then it does look like this item may need more clarification on multiple fronts. So then So I would imagine the second option that we were going to propose, which is also adding this as an alpha response into the CAV table, perhaps not the most it probably wouldn't be the most accepted proposal, eh? Okay, sounds good. So that's okay. We can skip that and we will look further into it later on. And I believe we are in the last stretch of the gaps that we're hoping to discuss for today. And finally, we have lungs. So first item would be cardiothoracic profile for the 6-minute walk distance. What CIHI is looking for here is the patient's most recent 6-minute walk distance at the time of listing and transplant in meters. We're expecting this to impact the pre-transplant nurse in terms of documentation and changes. So for this here, we found that adult patients are sent to the pulmonary function labs at VGH or St. Paul's for their 6-minute walk test. Based on some existing information we found, it seems like whether the documentation is done on PowerForm or on paper is dependent on the site. In several recent lung referrals at VGH, we found that the PF lab results, including the 6-minute walk, are scanned into patient files as a fax document. For pediatric, we realized this would not be as applicable since the patient base is shared with Toronto State Kids and workup for pre-transplant is done there. Okay. So for our analysis then, there is a 6-minute walk test section at that VGH pulmonary hypertension and VGH and St. Paul's PF labs are using to document the information. It appears that occasionally VGH PF lab results are documented in this section by the lab technicians, but several results are also scanned into patient files as fax documents, like I mentioned before in the analysis. So the option we're proposing here is to add the 6-minute walk test section to the new pre-transplant PowerForm, as we've discussed before for many other issues. The advantage here being meeting CIHI's requirements. It will also provide a discrete value for various the 6-minute walk test when it's documented on paper. But Of course, this will come with a disadvantage of change in the current state of workflow for the providers, nurses, and perhaps anyone that's transcribing this information. So from the long program, can we have some input on what you think of this proposal?
I think it's just going to be significant workflow. I think a lot of this is just asking us to transcribe a lot of different data in a lot of different places. We obviously do a lot of 6-minute walk tests on, we have like over 300 patients in our portfolio, and most of them are doing them every 3 months. So this would be a significant amount of work for us to transcribe every single patient into these.
I see. That was a piece of context I was not aware of prior, so really appreciate you mentioning that. I do understand CIHI is looking for this measurement specifically at the time of listing and transplant, so perhaps there may be some mapping that's required afterwards as well. But with regards to just fulfilling CIHI's data analytical needs, and aside from what you mentioned about how this will inevitably impact how things are currently being documented or how things will be documented, are there any other strong oppositions to what we're proposing here?
Just the immense amount of work it's going to be for, there's only 2 coordinators. So,
I see.
We'd be doing a lot of this.
Okay. So,
I just had a quick question.
Yes.
For Megan, do most of the patients go to VGHPF labs to have it done, or is it done by the coordinators?
So you're talking about the 6-minute walk data we receive?
Yeah.
So most of our patients are not doing their 6-minute walks at VGH PF lab or St. Paul's PF lab because they come from all over the province. So we have a mixture of patients that are doing teledoc visits, etc. So we're getting those faxed reports from all over the province from different PF labs.
Thank you for that.
Okay. And yeah, so thank you for mentioning all that. This is definitely getting noted. We'll have to look a little more into this afterwards. And as for another item for the cardiothoracic profile, there's what they're looking for is the FVC percentage predicted and FEV1 percentage predicted, as well as best percentage predicted for FEV1. So here, what CIHI is looking for is the patient's most recent FVC percentage predicted at the time of listing and transplant, patient's most recent FEV1 percentage predicted at time of transplant, and the average of 2 best measures of the FEV1 percentage predicted that were taken at least 3 weeks apart in the first year post-operatively. So with that said, there will be impacts to both pre and post lung transplant coordinators. The current state of this being that patients' most recent FVC percentage predicted and FEV1 percentage predicted only appears to be documented in the post side of the VGH lung clinic. And this is documented under the post-transplant assessment power form. And for pediatrics, this goes on the pediatric transplant assessment form as well. Pediatrics, again, since there's a shared patient base with Toronto, it's not as relevant for the session that we're discussing today. So part 1 of our analysis shows that patients' most recent FVC percentage predicted and FEV1 percentage predicted is not documented discretely until post-transplant in VGH solid organ transplant clinic. CIHI requirement for this information needs it to be also at the time of listing and transplant. And for pediatric patients, workup is done at Toronto St. Kitts. Then the option we're hoping to propose here for this piece is that we can perhaps add the lung transplant information section to the pre-transplant power form as discussed before. Again, this is already a recommendation as part of the EDD to add this information to the power form, and this will also help us meet the CIHI requirements. But this comes at the cost of ambulatory build and also transcription. Again, that'll be required by the pre-transplant nurses. Part 2 of our analysis shows that FEV1 and FVC are currently in free text, and like what we mentioned before with data entry errors and data quality, it's recommended that if we were to go through with the solution, we change that to numeric fields. Again, pros and cons for this being pros. This means the CIHI requirements, there's better data quality and no impact to historical data on the SMART template. But this would also come with ambulatory build and potential added work changes to the pre-transplant nurses. So here we would also like to hear your thoughts on what we have proposed.
I know there was discussion before I joined the team here. We already have a document that's an informal document called a clinical summary. Most programs throughout the country have them for lung transplant at least, where all of this data is input and lives. It's a Word document on every single patient where we keep track of all this data. And there was floated with the Cerner team, if they could create a clinical summary for Cerner, then all of this data would actually live in that document anyways, and it would actually, be congruent with our workflow rather than being an addition to what we do, because this data is already being tracked. It's just in a separate way. Just because this at current would just be, like I said, an immense amount of workload for us because we would be retranscribing this data multiple times. And so I'm just wondering, because I think this is going to come up quite a few times with some of the proposed changes, that if we can revisit what a clinical summary looks like for the lung transplant program, and if there's a way that this pre-transplant form, if it can become a living clinical summary, then it would actually be not only helpful for our workflow and our program, and it would be an amazing way to track data.
I see. Yeah, thanks for letting us know. I was not aware of that document's existence until now, so I understand Pat is on the call, and Pat may be noting these down. Pat, could you kindly ensure to have Megan's suggestions noted so that we can look into it further?
I have it noted already. Thanks.
Thanks so much. Alrighty. And with regards to further items for adding to the workflow for the lung transplant program, I do believe this might be it for the rest of the session because we're all done with the gaps. Now we're going to be moving on to existing fields in CST Cerner. So if no further questions with any of the gap items that we've presented, I'd be happy to move us forward to that. And I also have my eyes on the clock for our next 5-minute break, so I'll try to make the pacing work out well. All right, so moving on to existing fields in CST Cerner, and we're gonna again start with things that impacts all the programs. First on the list would be infection type and date. Infection type and date of infection identified. What CIHI is looking for here is the type of infection acquired by the recipient. So if it was diagnosed anytime during follow-up care, and not just immediately after the post-transplant period. The date or dates of infection or reactivation requiring treatment or adjustment of immunosuppression medication. 4 things they're looking for here are bacterial infection, fungal infection, viral infection, and unknown. This, we believe, may have impact on the post-transplant coordinators and the providers, or both. So with regards to infection type and, with regards to the current state of infection type and dates of infection identified, diagnosis of infection can currently be documented under problem and diagnosis. So if that is the case across the board, we are proposing to use a logic-based approach to map a list of applicable ICD-10 codes for infections and the date documented on the patient's documentation history to fulfill CIHI's required list of values. Please ignore the red text here. We're just working with CIHI to determine exactly what they're looking for in terms of bacterial infection, fungal infection, viral infection. But we are planning to use a logic-based mapping approach for what gets entered into the diagnosis field. So here I would just like to confirm with the programs and especially the providers and the nurses, would this be a practical way of addressing the shortcoming and ensure that data is collected? Just want to make sure that all of these relevant infections do indeed get documented under diagnosis and problem. Yes, Erin?
Hi, for kidney post-transplant at St. Paul's, I don't think every infection would be documented here necessarily. So
okay,
we would need a different way to make sure we're not missing things.
I see. Could you kindly speak on what might currently be missed or excluded for entry?
Well, I mean, I'm just thinking, like, is this for all, like, follow-up for the eternity that we follow patients? Was I understanding that right?
Give me 2 seconds here.
So anytime during follow-up
yeah.
care? So I
Yeah,
mean, we have a lot of patients we follow like lifelong, and a lot of them don't necessarily live in Vancouver, and a lot of our follow-up is phone calls by nurses. So I wouldn't think like every time a patient has a UTI or something, it's not necessarily documented under a problem and diagnosis. It might just be under a narrative note.
I see. Okay. So just to clarify then, even during remote follow-ups, problems are recorded, but they're just not necessarily entered in diagnosis and problems, like for that specifically, right?
Yeah, correct. I don't think everything would be entered under diagnosis and problems.
Gotcha. Thank you. Could any other programs speak on perhaps any variations to that issue? Yeah, Josie?
Yeah, we're like Aaron with the kidney program. We can't, some of our patients, because they are lifelong and some of them do get infections quite frequently, we can't always chart on every single infection that they get. So like the kidney program, a lot of it is done narratively.
Okay, thank you for that. And Dr. Winifred?
Yeah, I think at Children's we would have most of our new diagnoses would be charted under problems and diagnosis, but if it were like a recurrent urinary tract infections, we don't necessarily enter every single infection as a separate problem. We might change it from UTI to recurrent UTI. The same would be true if we had a viral infection. We might put it in, but we might not put in every subsequent recurrence. So certainly the serious infections we would capture, but we might necessarily miss recurrent infections.
I see. Thanks so much for speaking on that. Appreciate it. And yeah, if any other providers on call are able to speak on behalf of their program, just letting us know a little bit more about what are some of the issues we might need to look further into for this piece, that would be really great. And if no further issues, then we've definitely noted what was said now, and we'll have to perhaps also take this back to ensure this approach can still be moved forward with in its current state. But aside from that, Kaylee, would you be able to speak on any other issues we might need to look into for this piece specifically, other than taking back the feedback from now?
Yeah, no, I think that's great feedback, and maybe we can just clarify with CIHI if they're okay with that this would capture the serious infections and maybe not those recurrent, so we can take that one away to CIHI.
All right. Okay, so I believe this slide marks the end of our required time for providers and critical providers who are present with us today. We really thank you for your time, and we understand that we asked you to stay until 3 o'clock So if you have other matters you must attend to, you're more than welcome to stay and listen in, of course. But if you have other matters you must attend to, we'd like to give you 5 minutes of your time back. Except for Dr. Wendifer, we do have a few issues regarding BC Children's that we would like to consult you about. I guess this would be a good time to give everyone else a 5-minute break. So during that 5-minute break, if we can trouble you for a few more questions.
Yeah, that'd be fine.
Okay, sounds great. Thank you. And as for everybody else, please feel free to take a 5-minute break and we'll reconvene at 3 o'clock. Thank you. Okay. So we do have the slides towards the end here that are specific for existing fields that will impact the pediatric program. Most of them have pretty much the same requirement, is just for having a identified developmental issue or diagnosis. What CIHI is looking for is the identification of these problems at the time of listing, transplant, annual follow-up, all the way until they're no longer being followed by BC children. And with all the approach, it's also pretty consistent. And it's just that if a relevant diagnosis were entered under problem and diagnosis for any cognitive issues, we would do a logic-based mapping to fulfill what CIHI is needing for the yes, no, and unknown responses. In your expertise, I guess specifically for the kidney program, would this approach suffice for meeting CIHI's requirements?
So I think it would for post-transplant because of our approach to annual assessments, but I'm not sure that it would for the pre-transplant evaluation.
I see. For the pre-transplant evaluation, then.
So yeah, at time of listing, we would probably have that information most readily in the social work assessment pre-transplant.
I see.
And so whether that's something that you can pull from a document or whether that's a separate form, we would need to have included that as a discrete data field in the pre-transplant assessment form.
Okay. No, that's good input. So I appreciate you pointing that out.
Sorry, just
Kaylee,
a quick question on that. Oh yeah, sorry, Ryan.
No, sorry, you go ahead first.
Does that mean then that the social workers are the ones that assess for that and that at time of listing and right before transplant phase then?
Right, they're routinely doing that at this time, and then they bring it to our attention at the time of the pre-transplant assessment meeting.
Okay.
And would the social workers be in charge of entering anything into problems or diagnosis, or would that just be charted? And if it needs to be entered, perhaps it needs to be transcribed by a nurse or a doctor.
Yeah, that's it's not within the social work purview to add problems and diagnoses to Cerner. So
I see.
Yeah, so it would be discussed at the pre-transplant meeting, but it may not actually make it onto the problems and diagnoses until the first annual assessment post-transplant.
I see. So not a big problem for the post-transplant side, but with pre-transplant, it's a little more complicated. Gotcha.
Yeah, because we're collecting pre and post data on this. So.
Okay. Yeah. Thank you. That's again that during these meetings, it's always good to learn new things. This is one of those things that I wasn't aware of beforehand. So thank you for pointing that out. And I'm just hoping to see if there's anything else different with our approach for some of the other things here, like learning disability, but it all seems to be drawing from problems and diagnosis. So we'll take your input and we'll apply to that for all the other remaining problems here. But I think that should be all the time we need from you as well. And thank you again for attending our session today and putting in 2 hours. Appreciate it.
Great. Thank you, guys.
Yeah, thank you. Take care.
Thank you.
All right, everyone. So I do see that it is 3 o'clock. Can I quickly get a show of hands or a show of thumbs up emojis to see if everybody is back? Alrighty, I'm seeing few thumbs up, so we will proceed ahead with the rest of the issues here. And because these are existing fields within Cerner, I'm hoping we can perhaps breeze through them. But of course, any questions, any concerns, or if we require input from you, it's always welcome. Okay, so our next item on the list is a demographic piece, and that's sex at birth. So what CIHI is looking for here is the category of assigned to the recipient at birth that's typically based on the reproductive system and other physical characteristics. For things that they're looking for are female, male, intersex, and unknown. And regarding its current state, when an encounter is created on a patient, a message is sent to EMPI to verify the identity of patient to make sure all demographic information is accurate. Any patient, BC resident, or visitor who's had an encounter with the healthcare system will be an EMPI and have a BCPHN. Approximately 99% of BC residents are in the EMPI with the BCPHN, and it is considered a source of truth for the provincial health identity of any individual in BC. So the gender field that is currently in the demographics is actually the patient's sex at birth. Our proposed solution is pretty straightforward then. It's to map CIHI's list of values to CST Cerner values as female to female, male to male, intersex to undifferentiated, and unknown to unknown. Any thoughts, any concerns regarding this? Okay, if not, we'll go through with this recommendation and we will move on to the next item. So up next, similarly, we also have gender identity, and what this is the socially constructed role, behavior, identities, and expression of girls, women, boys, men, and gender diverse people by a given society, by which the recipient self-identifies at the time of referral. CIHI is looking for the following classifications for male, female, another gender, and unknown. So currently, this can be documented under social histories for genders and pronoun history. Once documented, our proposed solution would again be using a logic-based reporting approach to map CST Cerner gender and pronouns at the time of referral in the form of, for female, the selection would be female, woman, girl, or cisgender based on biological sex. Male, for man, male, man, boy, and again, cisgender based on biological sex. Another gender for identities including transgender, two-spirited, non-binary, intersex, agender, gender creative, or other, and unknown if nothing is filled out here. Any thoughts, concerns? I'm actually curious to those who are present that might need to record this information. Could you tell me a little bit, perhaps just a rough estimate, how often this information is filled out, and if it is currently a requirement for any given program?
I think it's done at admission for inpatients. And then I want to say it's also done when we have them like check in for clinic. Am I right, Josie?
Yes, yeah, on check-in to 5CD.
Okay. Thank you. Appreciate that. Just hoping to get an understanding, so just to see if there may be any issues with moving this forward. From what I'm hearing, this looks like something we can move forward with in terms of the approach. Any additional comments or suggestions are welcome if we need to circle back to this. So then we'll move on to alcohol use. This is just an indication of alcohol history that may pose a risk. So CIHI is looking for yes, no, and unknown. So we understand this can currently be captured under social histories for alcohol history. So what we're proposing here is a couple of things. So first, we can perhaps move alcohol history into the pre-transplant assessment power form that is to be built under the social history section. And this would just allow clinicians to capture this information upon transplant evaluation in a more consistent way. And when entries are made, we would also apply a logic-based approach for mapping what is selected to what CIHI requires. So our mapping logic is again quite straightforward, with yes being binge pattern abuse selected, it's yes, previous treatment, inpatient, outpatient, peer support group therapeutic programs, other, or completed cage aid power form selected as yes. No would just be defined as binge pattern abuse selected as no, previous treatment, none, completed cage aid power form equals no. Unknown being no documentation for the section at all. Any concerns, objections, comments? Would this be particularly out of ordinary with regards to the current workflow for documenting this information?
Speaking
think
to the
it's-
program, we do chart as much as we can, but a lot of it is narrative, but we just have to be more conscious of collecting those.
Sorry, Josie, I couldn't quite hear you there, but I think I caught it's perhaps documented more in the narrative, and there's something to be more careful about.
Yeah, so we do enter use, but I can't say for myself I've checked off binge pattern abuse or the previous treatments or completed the cage aid. So we just have to be more conscious of filling that out.
Okay.
If we were to add it.
I see. Thank you for that. And Erin?
So I don't strictly work on the pre-transplant side, but I just think all of these things, I just want to, point out again, I think they would need like a workload assessment before, because we're not even currently using a lot of these power forms. So although we kind of assess this, I think when we start adding like all these forms in where there's like a lot of boxes to tick off, we're just going to need to look at workload impacts.
No, definitely understand. And I'm not sure if I mentioned this before, but with regards to what we're trying to accomplish here, it's just that CIHI is giving us a list of requirements or demands essentially, and we're trying to meet them. Of course, you can't exactly force anyone to use something just because it gets built. So these are all things we'll take into consideration. Thank you.
Sorry, Ryan, is this, it's Sharon here. Is this just for, is this actually a requirement from CIHI, or
Correct.
are these recommendations or requirements? And what's the actual obligation to report on this? That's one question. And then the second thing, this power form is not built yet. Is that correct?
So to clarify, alcohol history exists in Cerner currently, but what needs to be built is the pre-transplant assessment power form that can be used across all programs.
Yeah, I've kind of have some concerns about the actual filling out some of this information, like if it's actual hard data, average number of drinks per day or frequency, that's one thing. But when they start, binge pattern abuse, or previous treatment, sometimes that's also a bit of a moving target. I'm just not sure that I'm not sure that about filling that out. And then I also share some of the concerns voiced before about actual workload to fill out some of this information.
Mm-hmm. Yep, no, I totally understand. Appreciate your feedback on this. Anything that's, expressed as a concern from clinicians, we're noting it down today, and these are all things we'll have to put into consideration moving forward.
I have a question.
Yeah.
I'm coming from the post-kidney transplant side at
Yes.
BHH, and I think I'm kind of confused, to be honest, everything we're talking about. Is this all just for admission or pre-transplant? Because I don't think this pertains to anything with post-kidney anyway. I don't know, maybe post-liver would use these kind of forms.
No, sorry, you're right. This is part
Okay.
of pre-transplant.
Okay. Okay,
Yeah.
just clarifying. Okay, thanks.
Yeah, no worries.
I also wanted to point out, like, some of the stuff, it seems like it's being defaulted to nurses, but we shouldn't, like, binge pattern abuse, like, technically you need a psychological assessment to
Mhm.
to determine whether that's yes or no. So echoing what everyone's said previously, I don't know if this is even a feasible solution, in my opinion.
Okay, no worries. Thank you for letting us know. Okay. So we've noted down all your feedback, and yep, we'll take this back and we'll see how we can get it addressed before moving on to the next iteration. Okay. Oh, sorry. Any additional comments for this piece? Just wanted to make sure everybody has a chance to speak. If not, then we can move on to the next. Okay. So up next, that would be smoking history, and the indication here being whether a patient is a smoker. Specifically by CIHI standard, this is for within the last 6 months. They're looking for yes, no, and unknown responses. So currently, smoking history can be captured again under the social history section for tobacco history. And the options here we notice don't match exactly one-to-one with CIHI's request. So the option, again, what we propose is for this to be added to the pre-transplant assessment form that is to be built, and it will also be included under the social history section. Indication for whether a patient is a smoker will have to correspond to the responses as we've outlined here. One slight issue is with how the responses here show for the last 30 days, and CIHI is asking specifically for the past 6 months. So going over the pros and cons quickly, there's greater ease for capturing this information and updating smoking history throughout a transplant evaluation. But again, this will inevitably impact the pre-transplant coordinator's workflow, shall the responsibility fall on them to document this. There's, like I mentioned, the possible conflict with last 30 days versus 6 months. Yes, Amina?
Akin to the previous question about alcohol use, nurses at St. Paul's pre-kidney transplant don't necessarily include this in their assessment right now. These explicit questions are more baked into the social work assessment.
Social work assessment, okay. That's probably an area we'll have to consider when it comes to more of the I guess, demographic requirements when it's coming for transplant patients. Okay.
Sorry, one more thing.
Yes.
I don't know if all the programs have a full-time or at least a social worker attached where all patients do have a social work consult. Because if they do, then maybe it's actually more reasonable to think about creating a power form with all these data that you need off of a social work assessment rather than under nursing.
This social history section is available across, I believe, social work as well. But we can check about that as well. But I believe social workers can document into these sections.
Yeah. Thank you, Kaylee, for clarifying that. The next one is quite similar to this. So that's regarding smoking rate. And to put it shortly, our current state and recommendations is quite consistent with what we have before. So Please let us know if you have any additional comments or concerns here, but otherwise we will also consider the input for this being more of a documentation responsibility by the social worker side.
Ryan, sorry, Sharon again. What exactly were the requirements or the requests from CIHI?
Oh, so this is for, I am so sorry. It seems like we missed the exact requirements, but just give me a quick second here. Oh, sorry. No, it's just asking for the number of packs the recipient smoked per day. And what we've identified is there is currently a field in the smoking history section for tobacco use per day. And that's where a clinician who would be responsible for entering this would be able to get that data in.
So the rest of the fields are not required, just this one field?
No, sorry, I think there may be some confusion. Could you kindly clarify your question? Are you asking about what is required by CIHI for the smoking history?
I was just asking about all the other like smokeless tobacco use, exposure to secondhand smoke, started at age, stopped at age, previous treatments.
Oh no, only so for each item, only what we've boxed in the in the red rectangle would be applicable.
Thanks.
Yeah, no worries. So yeah, if no different opinions on this compared to the previous item, we can also move on to the next. There seems to be a whole lot of smoking related items from CIHI. So again, recommendation is quite similar to what we have before. If this is indeed something that's more relevant for a social worker's workflow, we'll further investigate. And similarly, I guess, oh, hi, Samina.
Yeah, sorry, thanks. I just wanted to add, I would say social work and the nephrology assessment, both of those providers at St. Paul's pre-kidney transplant ask explicitly these questions.
Okay, thank you for that. And Megan?
Just from the lung program. So we typically do this in our new patient questionnaire because we don't accept referrals for patients that aren't abstinent for up to 6 months. Yeah. So this information is kept on that questionnaire that's uploaded into Cerner.
Okay. Yeah, thanks so much. I appreciate it. I believe what CIHI is looking for here is for patients who perhaps, and of course this varies by program, but patients who are perhaps still have these risk factors, including smoking and drug use during the assessment process. And that kind of ties into what we have on the slide right now, which is for marijuana use. CIHI is also looking for yes, no, or unknown indication. Once again, falls under social history. And can I please get some clarification on whether recreational drug use and substance abuse is also typically documented by whether it's social workers or providers for a given program?
For the heart, it's the social worker and psychology.
Social worker and psychology. Okay, thank you.
And kidney pre at VGH, it's the doctors put it in their letters if there's a history there, as well as the social workers do assess for that in their letters.
Doctors, social workers. Okay, thank you, Andrea. I'm seeing the hands up here. Okay, yeah, Megan.
Lung program, again, in that questionnaire, any substance uses come up, and then it'll be in the first consult note in the first clinic visit.
Consult note. Okay. And Erin?
For kidney at St. Paul's, it would be social work and the nephrologist, but again, not currently using this form, so that would be a change.
Understood. Thank you. And finally, Erin.
No, I think my hand was just still up from before.
Oh, sorry. Okay. So yeah, thank you for your input on that. As we mentioned, the proposed solution is quite consistent with what we had before. We imagined this would fall under pre-transplant assessment, so wanted to put it in that form. But again, if it's something that shouldn't be going there, we'll take it and we'll take your input into more consideration and see what else we can come up with. In terms of drug use, again, this time is for non-medical or recreational drug use that'll pose a risk. So here are some examples that we have. CIHI is looking for yes, no, and unknown. And again, we were hoping to include this in a pre-transplant power form and use a logic-based approach to map what choices are selected here. But based on the responses we received a second ago, we will take this back and see what else can be done to fulfill CIHI's requirement. Okay, now moving on to previous medical procedures. So what CIHI is looking for here is an indication of patient's previous medical history. So specifically for three things: history of cardiac surgery, history of percutaneous coronary interventions, and history of blood transfusion. Initially, we thought this may be an impact on pre-transplant coordinators, but please correct us in case there's, again, any issues with our current state analysis and proposed solutions. So what we found is for current state, prior medical procedures can be entered under history procedures. And so what we propose is then with having procedures, having procedures to be added to this EDD, which is the pre-transplant assessment power form, under procedure/surgery history. This will, again, allow clinicians to capture previous medical histories as CIHI requires upon transplant evaluation. Once a procedure history is entered, we can use a logic-based approach to map a list of SNOMED CT codes for history of cardiac history, history of percutaneous coronary intervention, and history of blood transfusion documented on the patient's files. So with that said, can we get your input on this approach that we're trying to implement? Hi, Andrea.
Just in regards to this, like sometimes our kidney patients have had multiple coronary interventions. And so I guess the question is around like, how recent do they want this information? I mean, this could go back years and years in terms of documentation of cardiac or capturing cardiac information.
Thank you for bringing that up. To my knowledge, what CIHI may be asking for is any of the relevant procedures that's taken place before. This may be a better question for BCT, who is also present. Nehemiah, would you be able to clarify what if I perhaps might be missing something in context here?
So I'm just taking a quick look at the MDS here.
Yeah, because to my knowledge, there's no limit to when a piece of historical data CIHI is trying to gather.
So it says it's just patient's medical condition history. So any history.
Yeah.
There is a specific list of set that they're looking for and they're interested in. But I don't know if that would help or make it more complicated.
Well, I think instead of leaving it open for us to fill in all the blanks, even having something like has your patient ever had any of the following? And there's a list, and you tick the boxes that would, like capture any of the things that would apply to your patient, would be maybe more appropriate than having to fill out each individual thing on your own, and it may be faster. So I would suggest something different that just has a list of things they want to capture, and you tick the box if it applies to you. Like, have they had cardiac procedures? Yes or no, check the box. Not on 1998, they had this cardiac procedure. In 2002, they had this cardiac procedure. Because if at the end of the day, they just want to know if they've had any history of it, that I think would be more efficient use of our time.
Thank you. That's a good suggestion, Andrea. I'm also curious to hear from other programs. Are there any other suggestions or different approaches that you may have in mind?
I think I just want to caution the same thing I said earlier about using the codes, is that there's multiple selections. Even if our physicians or even if the nursing group does actually enter it in, it's such a, such a broad base. If you don't mind going back to the previous slide of the categories in which they want us to, like, I think it might be difficult. Now, percutaneous coronary intervention, you might be able to capture that in the in the histories under procedures, and also of cardiac surgery. But that would be of the ones that have been performed since Cerner went live.
Okay. Yeah, thank you for letting us know that. Looks like
I'll just, add one thing. And I think that is why we've kind of landed towards this recommendation of using those SNOMED CTs, is knowing that those do get documented as they occur. And so then it would reduce double documentation where it had been done at a VPP site, opposed to like a checklist to just ask it. So when we came out with these solutions, we were trying to reduce the double documentation of what might be available in the system based on workflows.
But the problem remains that the physicians don't have time, even at current state, to put in these codes. And I don't see how we can change it so that they would have the time to review it, put it in, and enter every single one of these procedure or medical histories.
Thank you for that. We'll take this one back.
Just one quick thing, Ryan and Kaylee. I don't know, you guys probably looked at this already, but it might be worth just exploring, like in documentation. You can see like the case record from peri-op doc or even from SA anesthesia, which would have like some of these procedures selected from the MPTL. That would just be like a way of, because that information doesn't need to be manually documented again. It's just part of kind of the surgical scheduling process. So just a potential other avenue to look at.
Yeah, and they flow into here, don't they, Jesse?
Sorry,
into the procedure.
I think
those flow into the procedures. Yeah, so that's sorry what I was talking about earlier of like utilizing kind of that workflow, but yeah, but maybe it doesn't. That workflow doesn't happen for PCIs.
Yeah, that I'm not sure about.
Yeah. Okay.
So it looks like there is a little more investigation work we'll have to do, but yeah, I appreciate the feedback and appreciate the suggestions. Thanks, Jesse. Okay. If no further comments on this item, we do have a few more here. One of them being mechanical ventilation status. So this is just an indication of whether a patient was mechanically ventilated at the time of listing and transplant. This would be yes, no, and unknown. Current state being if a patient is ventilated, ventilation is documented in system access ventilation assessment. So if anything is documented there, we would use a logic-based approach to map the type of ventilation as an indication of whether the patient was mechanically ventilated at the time of listing or transplant. The mapping criteria is outlined as below. Yes for type of ventilation, invasive, non-invasive. No for nothing documented. Unknown being other ventilation assessment fields documented, but not the type. So for this piece, I don't think there are any direct workflow impacts specifically to the transplant clinicians, just because this falls under critical care. But we do have a minor concern to point out, and that's if a patient is to be mechanically ventilated or is in ICU as a transplant candidate, they will most likely be transferred directly to a VPP site from somewhere else. It's extremely unlikely for one to be placed on mechanical ventilation prior to arriving at VPP, but there is a non-zero chance. So just wanted to hear people's thoughts and input on this. And perhaps this will also be a good time. Nehemiah, for this item, this is consistent with CIHI's clarification for what they're looking for, correct? Sorry, specifically to the minor concern that we pointed out.
Sorry, I'm just reading over the minor concern here.
Oh, yeah. And while we have you do that, I do see Megan has her hand up. Megan?
Yeah, hi. I fielded a question last week from one of your colleagues, I believe, who was asking me about similar questions about ECMO as well. So when a patient's ventilated and where this data is found, et cetera. So if the patient is not at VGH and ventilated, that information is in obviously any consult note or transfer note that's found on Care Connect that states their settings, and that's kind of all the information we have. Generally for transplant, once somebody's on the to be activated, I told that colleague that they are transferred, at least for lung, they're transferred to VGH prior to activation, because logistics of getting a vented patient or an ECMO patient over to VGH once we actually have a donor is too difficult. So, but I'm just wondering and a little bit concerned about entering vent settings on a patient that's not currently at VGH into like an IVU or something like this. So like me as a pre-nurse coordinator sitting at my desk, of why I would be entering in that information when it's not my patient. I'm not sitting there I would be going off of whatever the latest consult note I have access to of settings, etc. And not everybody is versed in ICU knowledge.
No, absolutely. No, that's what I was hoping to point out with what I said before. I do believe this wouldn't exactly fall as a responsibility onto the transplant clinicians, but rather this is something that would perhaps get entered in a critical care setting. Like this information would be entered ahead of the patient being, let's say, urgently referred for a inpatient transplantation. Would that be correct?
Just so that I understand you correctly, are you saying if they're at a different site, so a non-Cerner site?
If they were transferred from a non-Cerner site to be ventilated at VGH, I think that's a better way to put it.
So that data would already exist in Cerner then? So I'm just wondering the changes that are being suggested. What is the suggestion here?
I'll just clarify. So we actually wouldn't be recommending that anyone goes in and documents this. It's just this is where you would take it if they were at a VPP site. If they weren't, we're just calling out, we wouldn't have this information because this would only be for patients who are in a VPP ICU ventilated.
I see.
Yeah. Essentially just taking the information that's entered here and mapping it so that CIHI gets what they want.
And I think the question, sorry, Ryan, would we be missing a large subset of patients by using this logic? Or are there a lot of patients outside of the VPP that might be ventilated prior to time of, or at the time of listing or transplant?
And based on what we're hearing, it seems like logistically that would not be happening at all. It would be more that if a patient were transferred to VGH first and then becomes ventilated, then consideration for getting them transplanted would take place. Am I correct?
They can be intubated at a different hospital, but they would not be, I think the terminology around time of listing, so they wouldn't be listed on the active list, and at least for the lung program, until they were transferred to VGH.
Gotcha. Okay.
But that they could be intubated at a separate site, so ventilation could be prior to that, but the ventilating settings at the time of listing would be from VGH then for the lung transplant program.
I see. Thank you for that. And sorry, Nehemiah, sorry, I cut you off there.
No, it's okay. I was saying for the heart program, I got a little bit of a different response from Wynn, but nonetheless, the patient will be assessed at St. Paul's to confirm these like mechanical ventilation status, etc., before they're listed as well.
Yes, and while they are at St. Paul's VPB site, if they are still mechanically ventilated, whether they were intubated before, as long as they're still mechanically ventilated at a VPB site, that would go on record. So we can take that information from what's recorded, right?
Yes, exactly. Yeah. So it should cover the time of listing and transplant.
Perfect. Okay.
I also wonder if it's in the actual OR report, whether they came in ventilated.
That, unfortunately, I cannot answer on the spot right now. What I am getting out of the input that was shared by everyone that contributed right now is that that we can move forward with this approach, and there shouldn't be too much of an impact. Is that right, Kaylee?
Yes, I think so. I just think maybe a little bit of investigation into that last point that Wynn just brought up around where it might be if they if it would be in the operative note.
Okay. Yeah. Okay. All right. Thank you everyone for your help on this. Do we have any, if we don't have any additional comments, questions, concerns, I can also move us to the next item. Oh, sorry, Dr. Marquez.
I don't know if you need the liver transplant input for this point, but we would rarely accept transfers of patients that have not been previously evaluated for transplantation who are on mechanical ventilation. Okay. We would be waiting for them to get to improve before they are transferred for an assessment. But otherwise, if they are here, yes, we try to capture the whether or not they are mechanically ventilated at the time of listing and also at the time of transplant, because it changes their status from a status 3 to a status 4.
Yeah. Okay, that's a good point. Thanks so much for pointing that out. Okay. All right. So it looks like we have a lot of good info here to look at that more at a later time. And yeah, like I mentioned, if no further input or questions, we can move on to the next piece here. So the rest of what we'll be discussing will be specific to the heart and lung programs, starting off with MCS/ECLS. And the first thing that Kaya is looking for is the type. So with these devices being used post-operatively, Kaya has outlined specifically what they're looking for in the list here. And current state we discovered is that either one of these would be used post-operatively and documented in iView under mechanical circulatory support, that's for adults, and pediatric mechanical circulatory support for pediatrics. So in terms of a solution, we're still proposing a logic-based reporting approach to map the following from the closure of the from the peri-op document forward. So the mapping that we have here is quite consistent with the choices that were given. Some of the remaining questions that we have is if anybody would be able to chime in and indicate whether so for artificial heart, there isn't a one-to-one choice right now within Cerner. We are wondering if that should always be associated with other, or if there's perhaps something that we missed in the existing choices.
So that's a good question. I actually don't have an answer for that. When I think that would be an offline question for Win in the group.
Okay, sounds good. Yeah. We can take it back. Okay. And just ensuring that we're not missing anything. So there's a note for. Oh yeah. So we are still investigating some of these some of these other choices here with CIHI just to see how they should be mapped exactly, but just so that everyone is on the same page for this. Sorry, any concerns from the lung program at all for this?
Again, because all lung transplants are completed here at VGH, so it's set in the operative note whether ECMO is being used post-operatively, and then obviously once they go to the ICU, the documentation on the ECMO would continue. So that data would be available. So I don't see any barriers. It's already being inputted in that flow. It would only be, I think the question I fielded last week was if there was preoperative ECMO, if they were cannulated at a different site. And so I sent an email to somebody about where that information would live, but I see no problem with this.
I see. All right. Thanks so much. Yeah, appreciate everybody's input on this. So this looks like an item that we, once we clarify the uncertainties with artificial heart and some of those things with CIHI, this is something we can potentially move forward with. And as for device use, CIHI is looking for the indication of whether mechanical circulatory support or extracorporeal life support devices are used at the time of listing and transplant. Looking for yes, no, and no. So I believe, Megan, this might be more tied in with the inquiry that you received last week for this. Our current state investigation shows that ECLS or intra-aortic balloon pump device start time and discontinuation time is documented in iView under mechanical circulatory support for adults. And again, for pediatrics is under pediatric mechanical circulatory support. Our proposed solution, again, would be using a logic-based approach to map the time patient was on ECLS or intra-aortic balloon pump compared to the time of listing and transplant. Mapping logic, fairly straightforward. Yes, for start and date time and insertion date and time and discontinue or removal date during the same time as listing and transplant. No for start date and time, insertion date and time, and discontinue or removal date and time, not during the same time of listing and transplant, unknown being nothing documented. Do have some pros and cons to discuss over here, and pros being this fulfills CIHI requirements. There shouldn't be any impact to existing workflow for this information getting entered, but this would require some reporting design along with some of the other logic-based approach that we proposed. Again, this comes with the same minor concern for if a patient were on these devices prior to coming to VPP, but based on what we discussed for the item previously, this, first of all, it seems like an extremely small chance of it happening, and most of the time, a patient would not be considered for transplant if they had been on these devices prior to coming to VGH. Sorry, not just VGH and St. Paul's. So with that said, do we have any concerns with the recommendation that we're proposing here? Hearing silence. So if no further comments regarding this, we'll consider moving this forward, and we'll move on to the next item. Once again, for the same topic, except what's being looked for is the separation date. So CIHI is looking for this in form of year, month, date. So currently this information gets entered in the same area that we discussed before under iView, mechanical circulatory support. And for pediatrics, it's a different band, sorry, pediatric mechanical circulatory support. So in terms of a proposed solution, we're thinking just extracting the date, month, year information under discontinuation off time and removal date and time. Does anyone see any potential issues with this? If not, if this is indeed as straightforward of an approach as we're thinking, we're happy to move on to the next item. Alrighty. So up next, again, this is still for heart and lung, we have anticoagulants. What is being looked for here is indication of whether patient was receiving anticoagulant therapy at the time of transplant. What we're looking for here are yes, no, and unknown. So anticoagulants use will currently be documented under BPMH. So then our proposed solution would then be using a logic-based reporting approach to map these drugs on BPMH as an indication of whether patient was receiving anticoagulant therapy at the time of transplant. So yes, if that was found on the medication list prior to transplant date and time. No, if not found on the list prior to transplant date and time, unknown being the medication not showing up there. Sorry, unknown being no BPMH and med list found. My apologies. For what we propose here, do we have any concerns specific to the lung and heart program? I guess better question may be, would we be able to ensure that the anticoagulants are consistently documented prior to patient receiving a transplant?
For the lung program, we do a BPMH at the first appointment, but that can be years prior to listing. So whether another BPMH is completed would be dependent on whether this patient's a patient of another clinic locally or another Cerner site. But for our patients up in Northern Health or things like that, it's likely outdated by the time of listing.
I see.
It would be only in the consult notes that it's getting updated, a medication list that the physicians will keep as a running list, but that's not necessarily updated every clinic visit.
Okay. Oh yeah, so appreciate you pointing that out. Would it be safe to assume, based on what you said, for local patients, this could be captured before they receive a transplant? Or would there also still be some compliance issues since they're not followed up, I guess, consistently at a pre-transplant clinic to the point when they get transplanted?
It's not necessarily the pre-transplant clinic. So currently in our workflow, we don't have a requirement to update this every time they come in. We only do one big update to input all of the medications they're currently on when we see them at their initial appointment. And then after that, it's only found in the consult notes, but it's not actually updated in the formal medication list unless they have a pharmacy review. So it would be highly individualistic based on that person's pathway through transplant. I don't think there's any formal process of updating it on a formal, regular basis at this point.
I see. Well, thank you for that. That's really good information. So we'll keep that in mind. And Sharon?
The patients do get a BPMH done when they're admitted to the hospital.
Oh, sorry, when you say admitted to the hospital, are we referring to when they get admitted to the hospital just prior to transplant?
Correct, yeah.
Oh, okay. No, that actually makes things a lot easier. So it seems like if a patient, because transplant surgeries happen on VPP sites, then if once a patient gets admitted to a VPP hospital in preparation for transplant, BPMH would get updated and this information would be extracted if needed. I see another hand up from Azmina. Yes.
Yeah, just on the nursing side, for living transplants that are booked in advance, the information of whether someone's on anticoagulation is documented in a 2-week pre-op nursing narrative note right now. And it's just a yes or no if they're on anticoag. And then I do believe that a pharmacist does check in with the patient if it's booked, like a booked living transplant in advance, but we would have to confirm with pharmacy.
No problem. And although our session today doesn't concern living donor recipients specifically, we do have that coming up. So this is really good information for us to prep later on. But I do just want to get some clarification then. So for, I guess, more relevant for deceased donor recipients, when they get admitted to St. Paul's, would it fall under the same procedure for them to get a BPMH update? And Josie?
Yeah, so for our patients, they do get a BPMH as soon as they're admitted to the ward upon the time of that they're going to be admitted for transplant. And then for us in clinic, the nurses do a BPMH with every clinic, and we do have a pharmacist as well that will do a med reconciliation.
That's
with every
perfect.
visit.
Thanks so much, Josie. Appreciate the input. So from what I'm hearing, it looks like this is a solution that we can proceed just because there would be sufficient information at the VPP sites before a patient receives a transplant. So thank you all for your input on that. And I believe we are very close to the end. So now we have a few items specific to the HEART program. First one being statin use at 1-year follow-up. So for this, with regards to workflow impact, I believe there may be some, including the pharmacists as well as the nurses who will be working with the patient. We realize this is currently also captured under BPMH. And so our proposal then would be using a logic-based approach to map 1-year follow-up appointment date with the BPMH record for statin that is on file. We're hoping to map yes to relevant medications with a status of taking as prescribed, taking not as prescribed or on hold, no being no longer taking or not found in BPMH, unknown being unable to obtain information, investigate in compliance, or no BPMH completed at the 1-year follow-up. Could the HEART program kindly speak on whether there's any issues with this approach?
No issues.
No issues.
Yeah, we do that with our patients when we're doing the med rec and the BPMH. So yeah, no issues.
Sounds great. Thank you so much. So then we'll move on to the next item for CRTD, CRT, and ICD. So this is an indication for prior use of cardiac resynchronization therapy defibrillator, cardiac resynchronization therapy, or implantable cardioverter defibrillator. We're thinking there would be mostly impact on the pre-transplant coordinators, but again, any issues you notice regarding this, please ensure to keep us posted. For the current state, we found that prior use of cardiac devices can be entered under history and procedures. Then we're assuming this gets entered, we're hoping to use a logic-based approach, mapping a list of SNOMED CT codes for what CIHI is looking for here in order to fulfill the requirements for yes, no, and unknown. Mapping logic is indicated as below. And we do have a note here saying that we do have a note here because we are pending some CIHI confirmation on the codes to use for these items. But at this time, this is how we will aim to proceed, assuming no further issues.
I don't have any comment for that. I think it should be okay, but
okay.
Like Wynn had mentioned, there's multiple codes for so many
Correct.
procedures. Yeah.
No, oh no, definitely. So what we're trying to make sure here to ensure that our mapping or anything regarding the mapping would be done correctly is for CIHI to get back with a list of what they're requiring. So therefore, hopefully that would minimize any sort of errors or room for error in here. Okay. No further issues with this. We have also previous cardiac history. So asking for an indication of whether patient had previous cardiac surgery. And what they're looking for is yes for cardiac surgeries identified, no for none of the above procedures documented, or unknown, nothing documented. The current state of this is being cardiac surgery is also entered under histories and procedure. So the proposed solution again would be using a logic-based approach to map what is available and what is entered under surgery and procedures in order to meet what CIHI is asking for. And the mapping logic again indicated down here. Can we have some confirmations on whether we can move forward with this?
Good question. So I would probably have a conversation with Wynn. I don't see it being a problem, but again, it's just being able to have the time to enter all this information in, but I don't see a problem.
Okay, understood. Yeah, thank you for letting us know. And again, if in either your communication or our communication with Wynn there happens to be any discrepancies or if there's anything else we need to be concerned with, please feel free to reach out. We'll make sure to note down anything that comes our way. And moving on to inotropic support. This is an indication for whether patient was receiving inotropes at the time of transplant. Just looking for yes, no, and unknown. Current state of this being the medication is documented in the MAR with start and stop time. So because what they're looking for is this group medication used at the time of transplant, we're also using a logic-based approach to identify inotropic medications, start and stop time, indicating whether a patient was on this shortly before they get transplanted. Our mapping logic is also indicated as below. So just hoping to confirm this is hopefully there shouldn't be any issues here as the patient would be an inpatient at the point in time where CIHI is looking for this information.
Yeah, because that would be that's what I was just going to state. This is an inpatient thing, so it should pull through, right?
Okay.
So yeah, no issues from our end.
Perfect. Thank you. And I see lung program impacts being the last of it. I am so sorry that it seems like we are going to it's going to be 4 o'clock in 1 minute. So if you must go, we appreciate your time commitment, but if you can stay behind for just a few more minutes, we're hoping to get through the rest of these very quickly. So starting with previous thoracic surgery. This is an indication of whether patient had previous thoracic surgery, and we're looking for yes, no, and unknown. And the current state of this being prior thoracic surgeries can be entered again under history procedures. So assuming that they are entered, we would use a logic-based approach to map that with SNOMED CT codes as defined by CIHI for what applies for the group of thoracic surgeries that they need for their requirements. Mapping logic indicated as below. And I'm just hoping to make sure, Megan, could you kindly comment on whether you see any issues with this?
I just pulled up a patient who I know has had previous thoracic surgery, and I see no documentation under histories and under the procedure tab. So I don't think this is a current practice of our physicians. Like I said, this data would be captured in their consult notes in past medical history. But it doesn't live in an easily pullable place at the moment. It's just written.
I see. Okay. That's something for us to note down, definitely. So perhaps not immediately moving forward with this suggestion, but we'll have to look into some alternative measures, perhaps. Okay. All right. So that is actually the end of our presentation. So we will be sure to include everything discussed today, anything that requires further discussion on the parking lot items. Just quickly to go over the next steps for those who are still in attendance. We will have a validation session for what's discussed today and what requires design. That'll be taking place in the coming weeks. We'll look more into the pre-transplant assessment form EDD and its development, and the slide deck for today's meeting will be distributed in the coming days. And any further questions or concerns, please feel free to contact me. I'll be sure to answer, or if there's something I can't immediately answer, I'll direct it to the right parties. Thank you all again for coming to today's session. Hope you have a great evening. Take care. Bye.
Hey, Ryan.
Hey.
Sorry, before we end there, I got my hand up a little bit late, but I was just kind of listening for the session here, and I do have a few comments, and I don't know if everyone needs to stay or not for this, but it's more around this whole process, to be honest with you. It's a bit concerning for me around this data. It's all data that's CIHI is looking for that already appears to exist in various forms. And so it's nothing that's new that's needed to be created to support clinical care. It's more for data collection for CIHI, from my understanding. So curious as to why the workload is being moved to the clinical side versus coders being able to go in and find this data after the fact. I just have some real concerns, and I was hoping that there would be a venue to be able to speak about this before it becomes a requirement, because I know right now it's this design and proposal, but I'm not sure where the right route to go for that is. As you've heard from almost everybody that's responded to your slides, is that looks like it could be done, but I don't know where I'm going to be able to do that. It's going to be more workload. Just curious how that's, where will that option or venue be to be able to talk to speak to that side of it?
So I totally understand your concern, and just to reiterate,
camera on here, sorry.
That's okay. So I totally understand your concern, and just to reiterate what we were trying to accomplish here for today, we are working within the constraints of what CIHI is asking for in terms of their requirements. So CIHI wants discrete fields for data to be captured, and therefore it can be reported in the way that they're requiring. I understand that a lot of these processes is going to add to the workflow and change up the workflow for many of the clinicians that we've presented to. So therefore, of course, when it comes to something with physician feedback being this is not practical, I believe this may be a better question for BCT, and perhaps this is something that they can help take back to CIHI and let them know this is the feedback we received on certain recommendations based on the constraints that we're facing right now.
Yeah, no, fair enough. And just to be clear, I'm not a physician, I'm the manager for the VGH clinics. But just it's around just the operational side of it, because it's going to become an operational problem when right now this information is already existing. So this is kind of going against, all of the clinics worked really hard with Cerner and whatnot when we developed our workflows. And this is basically going back and redoing the workflows to meet CIHI's requirements, which to me seems a little bit backwards when we worked so hard to kind of make sure that the workflows were meeting the needs of the clinic and the patients. So, this is theoretically, this is realistically, this is data collection. So it's data that already exists. So is there maybe a different way to look at trying to get this data rather than having to change the workflows again that everyone's worked so hard to create?
Yeah, no, I totally get what you're saying, and it's very reasonable. So this is something that we'll take back. We'll probably discuss with PCT, see what they can do with CIHI on their end to see how we can maybe remediate these problems. But yeah, appreciate the suggestions. We've noted them down, so we'll be sure to communicate them to the right parties.
Yeah, and I think I'll just add that the pieces today where it was brought up that this is transcription and there might be a discrete source for us, we will investigate those further as well.
Yeah, that would be great.
Yeah,
I think I think we all know that transcription leads to errors typically, and the more times you have to copy something, the more opportunity for error there is. And it kind of goes into the face of the whole dual charting that we're trying to not do, not have to ask more of our frontline staff to be doing this when they're already stretched as it is. So I don't know if CIHI is coming with a bunch of dollars as well to help support this, but yeah, I just feel that I just needed to make sure that gets noted, that we do need to have more discussion if this is going to end up becoming a requirement without any option. Yeah.
Absolutely. Appreciate that, Jamie.
Sorry for keeping everyone longer.
That's okay. No worries. So if we don't have any further questions or concerns, once again, just really appreciate everyone taking the time to attend this. And for now, enjoy the rest of your evening, rest of your week.
Thanks.
All right. Thank you, everyone. Take care. Bye.
Thank you, everyone.